Hi, this is Dr. Bhargava, and this is the next video in the series of body imaging case review. This is our first patient. We performed a CT of the abdomen and pelvis with contrast in a young female, and the finding was incidental and is in the uterus. We see this focus protruding into the endometrium from the myometrium and showing enhancement. And this is characteristic appearance of a polypoid submucosal uterine fibroids, and submucosal fibroids can cause menorrhagia, and when we see them on imaging like this, we want to report them, and we also want to use the FIGO location-based subclassification that is seen on this slide, and we have to give them a number that will range from 0 to 7, and the one that we saw earlier would qualify as stage 1. Here is our next patient, and the finding is seen in the bones, best visualized on this sagittal image of the showing the spine in the bone windows, and the bones, the vertebral bodies are sclerotic, especially near the superior and inferior end plates, and the axial image at the level of the kidneys is showing that both kidneys are atrophic, suggesting this patient has chronic kidney disease. And this finding in the bones is related to renal osteodystrophy and is called Rugger-Jersey spine. And here's a graphic showing the finding of sclerosis near the superior and inferior end plates involving vertebral bodies. This is our next patient. They presented with right lower quadrant abdominal pain, and in the right lower quadrant we see a lot of fat stranding around this tubular structure. This is better seen here. It's a blind-ended tubular structure which shows enlargement, mural thickening and enhancement, and is consistent with an inflamed appendix, and the findings are consistent with acute appendicitis. So this is bread and butter for abdominal radiologists or emergency radiologists. When we see acute appendicitis, we want to make the diagnosis and also tell the surgeons the location of the appendix. So here I would say that the appendix is retrocecal. So this is the cecum, it's behind it and it's pointing superiorly. Sometimes the appendix is long and it may be in the pelvis in this fashion. Also, if you see a hyperdense appendicolith, it's a good idea to talk about it and measure it. Sometimes after laparoscopic appendectomy, the appendicoliths are dropped in the intraperitoneal compartment and may be the source of future abscess formation. This is a companion image from another patient where acute appendicitis was diagnosed on ultrasound. Here is the axial image of the enlarged appendix, enlarged and inflamed appendix, and this is the sagittal image of the enlarged and inflamed appendix. We see hyperemia, we see mural thickening, and we see distension. This is our next patient, a female who presented with abdominal pain. We performed a CT of the abdomen and pelvis, and the finding is in the kidneys. The left kidney is normal. We can see the enhancement of the renal cortex. On the right side, we see a focus of hypoenhancement, which is also seen right there on the coronal and also on the sagittal image. So whenever there are foci of hypoenhancement in the kidneys, think about acute pyelonephritis. Ascending infection is very common in female patients, and that is because of the short urethra. It starts with cystitis. We see here that the urinary bladder shows mural thickening. Sometimes there is, or frequently there is, fat stranding, and through the UVJ, the infection would go rise up the ureters and will involve the kidneys. And acute pyelonephritis is seen on the CT as patchy areas of hypoenhancement involving one or both kidneys. The kidney may be enlarged and there may be some surrounding fat stranding as well. It may lead to abscess formation. This is a graphic showing the anatomy of the kidney. It is very important to know the structures. We have the cortex right here, and we have the pyramids. The pyramids open into minor calyces. Minor calyces, they join to form major calyces, and the major calyces become the collecting system that drains towards the ureter. This is our next patient. On the plain film of the pelvis, we find that there are multiple foci of sclerosis involving the bones in the pelvis and also in the spine. And so this is an appearance of osteoblastic bone metastases on plain film. If you read plain films, you may come across one of these, and you should be able to pick up osteoblastic bone metastases on plain films. This is a corresponding CT in the coronal image showing those osteoblastic multiple foci in the bones. Here's our next patient, and here the finding was seen incidentally that the SVC is distended and dilated, and there is a thrombus inside, which is also seen here on this axial image. And so when there is deep venous thrombosis, it may be occlusive or non-occlusive, and generally the vein is expanded, and inside you will see a filling defect, which is the thrombus. So here we see deep venous thrombosis with the thrombus probably extending from a right upper extremity vein into the SVC. It could be coming down from the internal jugular. Also, you want to do more imaging to figure out the other end of this thrombus. For upper extremities, it's important to know which veins are considered deep veins versus which ones are considered superficial veins. So deep veins are the subclavian, axillary, brachial, radial, and ulnar veins. The other veins, which are basilic and cephalic veins, are considered superficial veins. And when there is thrombus in the superficial veins, we call superficial thrombophlebitis. When there is a thrombus in the deep veins, we call it deep venous thrombosis. They both have different prognosis. So on ultrasound, it's very important to differentiate between the two. Here is our next patient. We performed a whole body bone scan. We are looking at anterior and posterior whole body images. They do not have a pattern of osteoblastic bone metastases where we see multiple scattered foci of increased uptake. They do have this focus in the sternum of a horizontal focus of intense uptake. And here, the other point I want to make is that we acquire images in anterior and posterior projections because the structures that are closer to the anterior camera head will be better seen on the anterior image, and the structures posteriorly located are better seen on the posterior image. And so this focus of increased uptake in the sternum is not seen on the posterior image because it's closer to the anterior camera head, and that's the reason we acquire both projections. And so this is from a fracture, and here is a corresponding CT image in bone windows showing this slightly displaced fracture, likely an insufficiency fracture, and we were looking for renal cell carcinoma metastases, which, as you know, are typically osteolytic, so they may not show intense uptake inside, but at the bone metastasis interface there is increased osteoblastic activity, and that will show increased MDP uptake on a bone scan. This is how a whole body bone scan is acquired. Patient is lying on the table 3 hours after the injection of about 30 millicuries of technetium-99m MDP, and the table moves between the first and the second camera head. The second camera head is behind the patient. It is not shown in this picture, but it's similar to the camera head 1, just behind the patient, acquiring the posterior image, and slowly the table moves so that a whole body scan can be acquired. Here's our next patient, and the finding on this CT of the chest in soft tissue windows is pericardial effusion. Here is the fluid which is around the heart, and the pericardium itself is thick and it shows enhancement, and so you should also raise the suspicion that there may be superimposed infection. The other sign of infection is if there are foci of air or gas inside this fluid. Here are two plain films of the chest showing an enlarged cardiac silhouette right here from a very large pericardial effusion. This is also called the water bottle sign, as seen on this image. And this is the reason why when there is enlarged cardiac silhouette, I don't call cardiomegaly on a chest x-ray. I say enlarged cardiac silhouette because if I say cardiomegaly, it means the heart is enlarged or dilated, but we know from this case that it could also be because of pericardial effusion. Here's our next patient, and we have performed an MRI of the abdomen for evaluating a right-sided mass arising from the right adrenal. This mass is seen right here. It's T2 hyperintense arising from the right adrenal. And so we are trying to characterize that better. On the right, we have DWI and ADC images showing high signal on DWI, low signal on ADC, consistent with restricted diffusion and malignancy. So on this middle image, which is a T2 weighted image with fat saturation, we find that there is diffusely increased signal in this mass. And there is some internal low signal, a focus of very high signal. So pretty much heterogeneous mass. And at the bottom, we have T1 fat saturated pre and post contrast images showing that there is contrast enhancement. So this high signal is also called the light bulb sign, and this is characteristic of a pheochromocytoma. And so this patient has a large pheochromocytoma arising from the right adrenal. We cannot make a histologic diagnosis on a CT, but you want to do either a Dotatate PET CT or an MIBG scan to make the definitive diagnosis that this is a pheochromocytoma, and also if there is any evidence of metastatic disease. This graphic is showing the different layers of the adrenal gland. It's a good idea to remember which layers produce which hormones and which tumors can arise from which layers. So adrenal has a cortex, which is labeled right here, and a medulla. The adrenal cortex has three parts: zona glomerulosa, fasciculata, and reticularis. A good way to remember this is the acronym GFR, which also goes for glomerular filtration rate. For glomerulosa, fasciculata, and reticularis, from outside to inside, glomerulosa secretes mineralocorticoids, fasciculata secretes glucocorticoids, and the reticularis secretes androgens. Adrenal medulla, we know, is of sympathetic origin, and it secretes epinephrine and norepinephrine. And pheochromocytomas are adrenal medullary tumors. That's why they take up MIBG, and also because they are neuroendocrine in origin, they will take up Dotatate on a PET CT. Here is our next patient, and we have two views of the chest, and we are seeing a finding you never want to miss. There is linear lucency below the diaphragms on both sides, and this is consistent with pneumoperitoneum from a bowel perforation. You want to pick up this finding all the time and then pick up the phone and call the provider that this patient probably has a perforation. This slide is showing different graphics of different signs that are associated with pneumoperitoneum. So starting with the cupola sign, which is air under the diaphragm, under the central tendon of the diaphragm. Then the Wriggler sign, which is the double wall sign where gas is outlining both sides of the bowel. The silver sign, also called the falciform ligament sign, where the falciform ligament is outlined by the free abdominal gas, as highlighted by this arrow here. And then the football sign, which is seen in massive pneumoperitoneum, where the abdominal cavity is outlined by gas, as seen here, and looking like a football. These are all the signs that have been reported on plain films from pneumoperitoneum. This is our next patient, a 33-year-old female with myasthenia gravis. We performed a CT of the chest, and it shows this mass in the anterior mediastinum, which shows enhancement. It's lobulated, it's uniform, and it does not show any features of regional invasion or heterogeneity such as necrosis or calcifications. This was resected and turned out to be a thymoma. This is our next patient, also with a mass in the chest, seen initially on a chest x-ray. This is the mass, and if I was reporting this x-ray, I would say that there is a mass that is in the region of the right hilum, and there is obliteration of the right heart border. This turned out to be a 23-year-old female admitted for acute appendicitis, and before they went for laparoscopic surgery, a chest x-ray was performed where this incidental mass was detected. And so the next step here would be to do a CT. This is the CT, which shows the mass being hypodense, heterogeneous, with not much not much enhancement, and peripheral amorphous calcifications. And so this turned out to be a teratoma. This is our next patient, also with an anterior mediastinal mass. This is a 31-year-old male with cough and chest pain, and you can see this multilobulated mass, and this is also associated with other lymphadenopathy in the chest, and it turned out to be a lymphoma. And so a biopsy is needed because the imaging appearances may suggest a particular kind of histology, but it's not diagnostic. And so either these patients get a percutaneous biopsy or a surgery to resect the tumor. Here is our next patient, and this patient was being evaluated for rising PSA, and so we performed a prostate protocol MRI of the pelvis, and we're looking at T2 weighted images in all three projections, small field of view on the top, and this is the prostate on the sagittal with this T2 hypointense focus in the left peripheral zone, which is also seen right here and right here. So this is the characteristic appearance of prostate cancer. It more commonly arises from the peripheral zone, which is T2 bright. The tumor is T2 hypointense, and it will show restricted diffusion as seen here, high signal on DWI and low signal on ADC. You want to use the PIRADS categories, and based on where the tumor is arising from, the peripheral zone versus the transition zone, you will look at DWI or ADC images or T2 weighted images and go down this path to give it a PIRADS from 1 through 5. Here is our next patient. They were diagnosed with prostate cancer and they underwent a prostatectomy. They presented with rising PSA, and we performed a PSMA PET-CT. The whole body image is on the left, showing urinary bladder activity and no abnormal uptake in the region of the prostate. Otherwise, we see physiologic distribution, and this tiny focus, which we are trying to localize on this zoomed in CT and fused PET-CT images. This tiny 2 to 3 millimeter focus is where there was recurrence that was proven later, and this is the smallest focus that I have seen of confirmed metastatic disease from prostate cancer being picked up on a PSMA PET-CT. This is our next patient. They underwent a CT of the chest, and the finding is incidental. This high attenuation focus is seen in the mid-esophagus, almost looking like a foreign body, but going through the records showed that they had a device called Bravo capsule. It is used to measure the pH of the esophagus in patients who have gastroesophageal reflux, and it stays in that position in the mid to lower esophagus for 48 to 96 hours. This is its appearance on the scout image of the CT and also the lateral view of a X-ray. And so it's important to know the devices and not call them foreign bodies or anything else. This is how it looks like. Here's a picture of the Bravo capsule device. This is our next patient. They have a history of prostate cancer, and we performed a whole body bone scan first. So on the anterior and posterior whole body images, we find some degenerative changes in shoulders, sternoclavicular joints, and the left foot along with the right knee. On the posterior image, in the lower thoracic spine, we see this focus of increased uptake that may represent bone metastases and should be evaluated further. And this patient underwent a follow-up PSMA PET-CT. And so on the PSMA PET-CT, we'll start by looking at the rotating image. We see extensive metastatic disease, which is PSMA avid. Most of it is in the soft tissues. That is why it's not seen on the bone scan. And the interesting finding here is this Virchow's node, which is in the left supraclavicular location, which is PSMA avid. Then we have this extensive nodal metastases in the abdomen and pelvis. And then that focus that we saw on the bone scan is seen right here as a sclerotic focus with increased PSMA uptake. So a good correlation between a subtle finding on the bone scan and more extensive soft tissue disease on the PSMA, PET-CT, and then the solitary subtle focus in a vertebral body along with a Virchow's node. This is our next patient. We performed a gastric emptying study. And so after they ate the standardized egg sandwich cooked using technetium-99m sulfur colloid 1 millicurie, we acquired anterior and posterior images of the abdomen, and we have drawn the region of interest and performed and derived a time activity curve. So after the technologists process the study, they will send you this image where the anterior images are shown, the posterior images are shown at different time points, and then the most useful information is right here, percentage retention at different time points. So at the end of 1 hour or 57 minutes, 89% is retained. Then at 2 hours, 81% is retained. Then at 3 hours, 77%. And then at 4 hours, 50% is still in the stomach. So this is a pretty abnormal study. Consistent with delayed gastric emptying, and these are the numbers you want to go by at the end of 1 hour of imaging. The residue or retention in the stomach should be less than 90%, at 2 hours less than 60%, at 3 hours less than 30%, and at 4 hours less than 10%. This is our next patient, a young female who presented with right flank pain. We performed a CT abdomen and pelvis to look for an obstructing renal stone. We see hydronephrosis involving the right kidney. That's the dilated collecting system. At the level of the UVJ, this is the obstructing stone. And so this was a very young 18-year-old female who was diagnosed with this obstructing stone. Compared to a previous study from 1 year ago, we find that this is the stone that has now moved to the level of the UVJ and causing obstruction. So frequently when you look at the prior studies on these patients, you can find the actual stone, where it was located, and how it has moved to cause the obstruction. There are 3 sites of physiologic narrowing of the ureter at the level of the UPJ, pelvic brim, and also at the level of the UVJ. This is our next patient. We are looking at plain films of the chest and the abdomen. The bones are very dense, and one of the causes of very dense bones is osteopetrosis. These are barium swallow images from 3 different patients showing different findings. Here we have an osteophyte, which is causing a mass effect on this contrast column going down the proximal esophagus. Next, we have similar finding of mass effect on this contrast column, this time from ankylosis of these cervical vertebral bodies. And then we have this diverticulum, which is Zenker's diverticulum, arising posteriorly from the upper esophagus. So multiple findings on barium swallows. They have to be recognized and reported. Thank you for watching.